Okay.
All right. Good afternoon. This is
All
Travis.
right.
We're going to start with Howard here.
Okay. So this is going to be a cause of pancreatitis that is not on your differential diagnosis list as an etiology for sure. So you'll see the presentation in a moment, but apparently this patient did present with upper abdominal pain acutely, and her lipase level was high, and I'll show you that in a moment. So here is a chest radiograph, and for sure you will not be able to make the diagnosis. There's nothing, let me just fix the thing. There's nothing obvious here for sure. You'll see in a moment when I show you this, that this down here, this interface, let me just bring that up. Really subtle. It's going to turn out to be a thing right here. So here is the CT, and I'll bring up the coronal CT, which shows this really nicely. So does the SAG. So we go here and look to see where the pancreas is. There it is. Spleen and kidney. I'll bring up the SAG and show you that the pancreas is protruding through the diaphragm into the lower chest, right there. And presumably a little constricted there, or so it was thought. So here is the clinical context as well as additional information. So she has a history of a congenital diaphragmatic hernia in childhood. No complications since then, presented with the pain as I described, as you can see there. Here you can see the op report, how they identified the pancreas and the small defect there, and how they basically fixed that. So it almost seems too good to be true, but whether the pancreas was a little bit squeezed, mechanically squeezed, actually causing a little pancreatitis, kind of fits given her presentation, presumably.
That's really interesting. So they think it's, I like it. Is that, they think it's more mechanical rather than ischemic?
Yeah, I don't know, mechanical or ischemic or a little combination of the two. For sure, there was a little defect there left behind from that, undoubtedly.
So fax is the way to go.
That's really interesting.
Isn't that interesting?
They'll send me the same form by fax.
And you're right. That was not the part of my differential for this. I mean, I know that you can get it from trauma, so I guess
7.
This is a form of trauma.
1, 7.
Yes. Why she developed symptoms at this particular occasion, if it's from that, with the lipase, is of course a mystery. But it seems to be the case. So they fixed that. Isn't that interesting?
Yeah.
Would have guessed, no chance. All right, let me show you this cardiac case. So this is a case of a person that presented with a whole clinical picture of sepsis and ultimately diagnosed with endocarditis. And I will show you the endocarditis involving the aortic root. So literally here we have a little pseudoaneurysm in relation to the left coronary sinus, left sinus of Valsalva. And a little bit inferior, you can see that there is a fair amount of opacity around it. And you can see its connection with the ventricle right there. So here is a nice clinical or surgical correlation. So we have an aorta to left ventricular fistula, pseudoaneurysm involving the left coronary sinus. And you can see here that goes along with what we see, a description of, there was a lot of phlegmon tissue present on the posterior to the aortic root, which was removed. You can see how It was the abscess cavity. They had a large defect. They had to fix that with a pericardial patch in that location to fix the sinus. And then they put in a valve. So, yeah, nice correlation between what we see on imaging and the findings at surgery. Again, attributed to Staph aureus bacteremia and aortic valve endocarditis. Anything about this that doesn't make sense, Travis? It all seems to fit very nicely, Travis and David.
Yeah, agree. I think that it looks like it may be involving part of the mitral aortic intervalvular fibrosa, that portion of the aortic annulus that's the least vascular and the most susceptible to infection or injury.
Okay.
So,
Okay, good. Let me show you this one. This one is sort of, in a way, back to basics, but you know, when you read a lot of bedside radiographs in really sick patients, and sometimes, as in this case, the findings that are of some relevance were not really identified. So the clinical context, of course, is a very ill patient. This patient's on veno-venous ECMO, has a tracheostomy tube, has a lot of lung disease. But for a couple imaging exams, I will show you that, and I'll put some alongside here. The finding of some relevance was not seen. So let me now mag up this exam. And I'm actually just going to point to the findings. So you guys feel free to make any comment. But in this location, here is one finding, and it's related to this. Right there. So that is a thin stripe, a couple millimeters, but that is the right tracheal wall. And we see it as a white stripe along its length because there has to be air both within and outside of it. So that is a double wall sign in relation to the trachea there of pneumomediastinum. So let me bring in another exam to show you that as well. Now here, and this is to show some signs of pneumomediastinum, is a really nice example of the double wall sign in relation to the right tracheal wall. But this time we actually have the equivalent of the ring around the artery sign, except that the air is about this portion of azygous vein. So it's a partial air about azygous vein sign. And then I want to show you one other thing, and that is when you look at the left ventricle here, the left cardiac margin, notice compared to here that now we have a sharp interface between the heart and air. We didn't before. So what is happening here is that there is air that's paracardiac, it's in the paracardiac fat, and sometimes, for lack of a better description, I call this the appearing, not disappearing, but the appearing heart sign, in the sense that when you have a situation where fat effaces the cardiac apex, if you put air in the fat, you then get a sharp interface between the heart itself and the air in the mediastinum. So we have the double wall sign, the air around the azygous sign, as it were, and then I just call this inelegantly the appearing heart sign of pneumomediastinum. Any comments, guys? Just a nice teaching case of signs of pneumomediastinum, which we attribute to the Macklin phenomenon in this patient on a ventilator.
Very nice.
Okay. Let me show you this one. This is just a nice example of seeing a radiograph and really puzzling about it. So first thing to notice about this, let's say an asymptomatic patient, is that the sternal wires are relatively small. We see some surgical clips. So we're thinking of prior surgery, maybe at a relatively young age. Of course, the interesting finding is the presence of this, which is clearly a tubular structure. and the person has had a prior surgery. You can see that from some rib deformity there. So this is an example of the bypass from ascending to descending aorta, bypassing aortic coarctation surgery. So here we don't have contrast, but we can see the bypass from ascending aorta, it's got some calcification, to descending aorta. So that's what accounts for the radiograph. So aortic bypass, bypassing aortic coarctation. I don't know the exact sequence of surgery in this patient, but there are clips there and clips there and so on and so forth. And I'll show one more. Let's see if this one is. Maybe not that one. Okay, I'll show this one. So here is, I'll put up a frontal and a lateral. So this is the situation when one sees devices, and we clearly have a left pectoral CRTD device with leads in the expected locations in right atrial appendage, right ventricle, and a coronary vein, except we have one additional fourth device, which one can see here on the lateral projection. So here we see it on the frontal, right here, but you see the length of it very nicely on the lateral projection. You can see that it has a defibrillation coil. So this is the situation when, in order to reach a defibrillation threshold during the period of testing of the defibrillation coil, it was necessary to put an additional defibrillation lead in somewhere. And I've shown a case previously where the additional lead was placed in the azygous vein intentionally. Usually I think they don't like to put this in the coronary sinus, at least initially, and I don't know the sequence in which this was done, because you may need the coronary sinus to put a coronary vein lead in. But here we do have a coronary sinus extra defibrillation lead put in order to achieve a defibrillation threshold. So sometimes they need to do that in order to successfully defibrillate. So there's a period of testing, and sometimes it's deemed necessary to have an additional lead in. And I think it's the shocking with a couple of vectors, both from here and there, that enables one to reach a defibrillation threshold and successfully have a defibrillation setup. So I think this is the first coronary sinus defibrillation lead that I've seen. I've seen one in the azygous vein.
Question for the group: are you guys seeing them? Your cardiologist place His bundle leads for pacing?
Yes,
We've started to
maybe
see some of those.
Yes. Yep. I've seen that. I can show that next time, but I've seen one.
It would be nice to just review the concepts for some of us, or someone to review the concepts behind it, because I don't completely understand it yet. But
okay, yeah, remind me, and I'll show. I think I've got maybe 2 cases, and then I can also remind myself of the indications for so-called His bundle pacing. Yep.
Cool.
Sure. I'll do that next time. Okay, Travis, can you take over?
Sure. Peter, do you want to go?
Sure, I can go.
You should have a prompt.
Yeah. You guys see it? See my screen?
Yeah.
Okay. So my first case is a 34-year-old patient that came in with respiratory failure. He had an acute asthma exacerbation. He got admitted to the ICU. They put him on veno-venous ECMO, and then he developed cardiac arrest, and they had to switch him to VA ECMO. And so for some unknown reason, the team ordered this chest CT protocol after he was already on VA ECMO. And I found it really interesting just because it kind of highlights the hemodynamics of VA ECMO. So as we scroll through, the main thing that stands out is the abnormal distribution of contrast. So there's contrast, you can clearly see a lot of contrast in the aorta and then in the right heart, but there's no contrast in the blood flow of the LV and then the left atrium. You could see perfusion through the coronary arteries, and then the contrast draining into the coronary veins and then into the coronary sinus, but the actual cavities are not opacified. So that's, of course, related to the way VA ECMO works. So I just included a nice review article here from 2019 and had a few interesting, good diagrams. So pretty simplified here. Circuitry, just the blood is collected from the venous system, goes through an external pump and oxygenation, and then pumped into the systemic circulation. And that kind of explains why we don't see any contrast in the LV. Both the lungs and the left ventricle are bypassed. So this provides support to the respiratory support as well as hemodynamic support. Now, the main complication of these is that there's very high afterload placed on the LV and really high LV strain. So that's you could kind of see this here. You see how dilated the LV is. So this is a young patient. He didn't come in with any heart disease. So this is basically LV strain that's iatrogenic from the ECMO. And secondarily, you get all the pulmonary congestion with this dependent edema that's below the level of the ventricle, essentially layering down. And then they kind of go into more in depth here in the article about this complication. Oh, by the way, you can see the increase in VA ECMO use now over the last decade. New data for resuscitation, and then they kind of go into detail, a little bit more detail here about what's happening in the ventricle as you increase the ECMO flow. You can see these are pressure volume loops. So the baseline pressure volume loop is the blue loop. And then with increased flow, you can kind of see how the pressure volume loop moves to the left and becomes significantly more narrow. So the stroke volume is the width of the loop is significantly less, and the loop is much further to the right. So there's much higher end diastolic and systolic volumes and pressures, which is what we see here. And then they kind of talk about the strategies to address this overloading of the LV here. So you either put Impella, intra-aortic balloon pump. They can even do a septostomy to create an artificial shunt from left to right. But in this case, if you do follow-up radiograph, they just put an Impella device.
Very interesting. So, can you window it so we can see? So is there a catheter in the SVC and IVC?
Yeah, the CT.
Yeah. Just so we can see what.
So you can see the superior vena cava catheter in the IVC cat. So this looks like a veno-venous ECMO, but when I checked the chart, I saw she was on VA, so I called the nurse to verify. They said they switched her and they have a cannula also in the femoral artery, which you can't see on. So the arterial is coming through the femoral, and then the reason you have all this opacification of the aorta is because there's retrograde flow, obviously, from the femoral artery. But because the heart because there's such high afterload, I guess the aortic valve is not opening. So you don't see the contrast goes retrograde, but it stops at the valve, and you get good perfusion to the great vessels and coronaries. But the heart continues to dilate, which is not really ideal. So they have to kind of decompress that.
Nice.
Yes, a couple of weeks ago, I showed an instance where the patient had central AV ECMO. So the arterial cannula was in the ascending aorta, but they recognized that there was a problem with left ventricular overdistension at the time of placement while the patient was in the operating room. So in that situation, what they're able to do is they place in a left ventricular vent via the right superior pulmonary vein into the cavity of the left ventricle, and that's to decompress the left ventricle. And the other side of the vent cannula is connected to the venous side of the circuit, so the venous side. So that's left ventricular decompressive venting in the case of central AV ECMO. But they can put the vent in because the chest is open. Otherwise, you have to use another way to try and decompress that ventricle, like an impeller device.
Yeah. So is it the VA ECMO patients like this that tend to get the more whited out lungs than veno-venous ECMO, just because of the dependent edema as you're talking about here? You guys know?
Based on the article, that's what it seemed like, is that the pressures, the afterload increases significantly with the VA ECMO. And I'm not sure with the veno-venous how that. I mean, obviously the lungs are again bypassed, but I don't know if the left ventricle has to push to get such a high afterload with those.
So this explains why I've seen these ECMO people with impellers at the same time. I thought that was excessive, but now I understand the reason for that. This is really helpful.
Yeah.
Sometimes a impeller device is placed in patients with just plain old cardiogenic shock. But the other use of an impeller device is to decompress an overdistended left ventricle in this kind of situation.
And back to the original question, Peter, the thought process behind why the patient might have a pulmonary embolism and why that could even possibly matter.
I actually I called the team, and it was I talked to one of the interns, and he said he wasn't sure. They just didn't know why they ordered. I mean, it wasn't really diagnostic. It wasn't very diagnostic either, but
the other thing to remember too, when it's pertinent, is that if you have to perform a CTPA for PE in patients in this kind of situation, if you know about it beforehand, you can make a special arrangement to quickly diminish the amount of blood flow via the ECMO circuit just for the period of injection of contrast medium, so that you get a diagnostic CTPA, and then you increase it again, or you sort of just briefly suspend.
I would imagine doing a portal venous phase or some sort of delay would also be effective, just like you do with patients that have congenital heart disease and circulations.
Yeah, that might work too. Yeah.
Interesting.
Yeah, Howard, I'll have to look back and find your case. I think I might have missed that day that you showed.
Yeah, the reason I showed it is because the metallic portion of the left ventricular vent, and it's small, can show up on an image, and then you don't know what it is. When I first saw it, I had no idea what it was.
Yeah. Okay, I can show my next case. This was just a coronary CTA, and it was essentially unremarkable except for an abnormal course of the RCA. So here approximately it looks, so the RCA looks fine. It's in the AV groove. And as you go inferiorly, it starts the course into the atrium. So this is a intracameral course of the RCA. I'm not sure how common they are. I think I've seen one other one over the past year. I'm sure you guys have seen these once in a while.
So is it dumping blood into the right atrium? It seems to, or is it just in the wall?
I think it's just in the wall. I think it's in the cavity.
In the cavity, but
I
not.
I don't think it's dumping.
Right. It would be much larger if it were.
Right.
All right. And one last one. Travis might appreciate this one. So this patient was first came into the hospital last month, earlier last month, for multiple falls. So they did a brain MR,
Partial clearing of airspace apostasis.
Show his diffusion weighted imaging here. You can see he has multiple areas of restricted diffusion in different small foci here. So in different vascular territories. And so
Compare.
a few days later, they decided to do a cardiac workup. So this was on this was like 4 days later, October 5th, 17th. So the part of the cardiac workup was this coronary CTA, and then the coronary CTA, one of the indications, it said chest pain, but one of the other indications was they mentioned that he'd had an ablation for treatment of atrial fibrillation about a month ago. It's at an outside place. So this was read by my colleague Stefan Tigges and one of our good residents, Ross Christopher, and they made this good observation here. They saw a little bit of air that they were suspicious about that looked right outside, right here. So they were worried that this might be outside of the esophagus, especially given the recent history of ablation. So they went back and they actually looked at this CTA, which was done several days prior. And you can see multiple small pockets of gas also in the brain. So that would explain explain the strokes. And so they called it a left atrial esophageal fistula, and the patient went to surgery and they were right. And here's the post-op. It's not that the post-op's not that interesting, but you can just see right there's where they put the patch. So this is the repair, and then here's the swallow study post-op. There's no leak.
Today.
That's
Yep,
it.
it's an example. Yeah.
Yeah, I think, Howard, you've seen probably, what, a half dozen of these, as have I?
Yeah, maybe not quite that much. Well, maybe it's about 4 or 5, I think. We did an exhibit, didn't we? I think that Jeff did that, or you did.
Yeah, we included
had
it in that SD one, yeah.
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 Between us, we had about a half a dozen cases, I think, of different kinds, about something like that.
Yeah. Peter, can you go back to the CT, the coronary CT? Because, yeah, because these always develop along the pulmonary venous ostia, wherever they, ablate. But it's interesting because it looked like you were showing the patch was on the right-sided pulmonary vein.
Yeah, it seemed like it was right on the right inferior pulmonary vein, but this is where the gas is there.
Well, but that gas could just be between the esophagus, in the pericardial space, just like you see stuff anteriorly there. Because I don't think all of that is in the atrial appendage, do you? Or maybe it is, but
no, it is in the atrial appendage. We asked the cardiologist that had done a bubble study, which was negative, and the sensitivity for a bubble study is very high. So they wouldn't have. We were worried that there could be a atrial defect.
So the air in the right atrial appendage is unrelated then, right?
Unrelated, yeah.
It's just from a venous flush or something.
Yeah, and then there's no shunt in the shunt based on a bubble study.
Yeah.
Interesting.
That's all I have.
Great cases, thank you.
Thanks.
Okay, anyone else have cases they want to show? I don't know. Or it'll be me.
Yeah.
All right, this first one is an interesting one I saw the other day, and it's a little bit of an eye test on the radiograph, and I'll show you guys the PA and the lateral view. And so you can look for a second and see what catches your eye. Anyone?
Can you zoom up, make them big just for a moment.
Or in those vertebral bodies.
Yeah.
Just below the aorta.
Vertebral bodies behind there.
Right, it's very interesting because it's like 4 contiguous vertebral bodies, and when you look, there's a little bit of, there's definitely just increased density of those bones in general, and there's kind of loss of the normal cortical medullary, interface that we see, and so that got me curious because, of course, a middle-aged or older female wonder about breast cancer.
I think
Maybe,
now that I see that on the projection, I can see an abnormal paraspinal interface right at the level of the hilum above here. The more one looks, the more one sees.
Yeah, I think
abnormal
exactly.
On both sides.
I think you see it on both sides. And then I was wondering, could this be some sort of multi-level infectious process like tuberculosis or something? I'll show you the radiograph that she had 15 years ago, and you can see that there's similar, it's progressed, but there's definitely increased sclerosis at this vertebral body level, all 3 of these levels. It's more conspicuous than now. And Howard, after you point that out, let's look at the PA view. I don't see as much of that, or really any of that paraspinal widening. I think this is aortopulmonary interface here. Yeah, that's a good observation right there. But this lady's had multiple spinal CTs and MRs over the years. This is one from 2017, and you can see a little bit of soft tissue surrounding there. And her history, and I'll show you a sagittal on this.
This is extramedullary.
No, it's not. She doesn't have that history. The only history she has is psoriatic arthritis.
Oh, really?
And and she's had an extensive workup for infection, always been negative. And so this is presumptive, just seronegative spondyloarthropathy related to psoriatic arthritis. It just happens to be involving multiple contiguous levels here. And this has been, as I showed, this has been going on for at least 15 years. So I'm curious if anyone has a better explanation. It seems reasonable to me. You have some end plate erosions. And looking back, I didn't see any other involvement of joints, at least on the chest radiograph. I didn't dig into the rest of her joints, but I know David in particular likes to look at the acromioclavicular joints and the shoulders, and everything else looks normal. But I thought this was just an interesting one based on this is what jumped out at me on the lateral and got me looking back through everything else.
So what do you think? You think that the soft tissues that are surrounding that are hypertrophy are just part of the inflammatory response? It's sort of extra articular inflammatory component?
Yeah, I don't have a better explanation. I don't know if anyone else has some bone experts they can show it to that would have a. But yeah, I think it's probably some sort of proliferative arthritis.
Wow, that's so interesting. I've never seen spinal psoriatic arthritis, vertebral, paravertebral ever before. That's so interesting.
Well, right, and it does make you wonder, could it be some smoldering multi-level infectious thing? But the fact that it's been going on for almost 20 years and they've done an exhaustive infectious workup. Yeah. So
very interesting.
Very cool.
Very interesting.
More radiographs, and this is one that I've held for a while. I haven't shown. I've shown other examples of this, and this is kind of interesting. This patient who's 80 plus has had a prior coronary artery bypass grafting. They have a lot of atherosclerotic calcification of their aorta, and not surprisingly, they have a known type B dissection. We can see the displaced intimal calcification, or at least this increased rind of soft tissue around the aorta, as you can imagine, just thickening of the wall from the chronic dissection. And you can even see it a little bit on the lateral here between the calcified portion of the aorta and then the non-calcified portion. So this, unfortunately, I don't have anything prior to this, but this was at noon, and she came in with worsening back pain and uncontrolled hypertensive crisis. And then this was this was, I think this was 10 hours later. And I don't know how much of this, you know, is projectional or not. I just show it because it's a good example of a dissection on a radiograph. You know, if it's perhaps getting a little bit, you know, thicker here, or if it's just the difference in projection, because there certainly is a change in angulation. But, you know, the thought was maybe this was a little more unstable given her uncontrolled hypertension and the fact that there was a new small pleural effusion surrounding it. But you can see that here's her dissection involving the arch and then the descending thoracic aorta. So just a nice radiograph, and you can see prior infarcts with thinning of the left ventricular myocardium in the LAD territory and elsewhere. But I show that one just as like a typical case that we don't see all too often, and I use that to set this one up that I just saw yesterday. This is a patient who has a known thoracic aortic aneurysm. This was back in June. Comes into the emergency department with a stroke, left upper extremity weakness, hypertension, chest pain, back pain, and now you can see this is 5 months later. This is clearly a new displacement of this or widening of the aortic arch. And you can also see there's a little bit of increased convexity along the right heart border. I don't know how much to make of that, but certainly this is, you know, a worrisome finding.
Yep.
And by the time she got to the operating room, she was becoming progressively hypotensive. And I'll show you, just not surprisingly, she has the displacement of the calcification. You can even see the dissection flap on the non-contrast study. See a little bit of high attenuation stuff in the pericardial space surrounding the right coronary artery. And you'll see it better on the post-contrast. But here we can see this is a type A dissection. And what's interesting here, this was a more of a venous acquisition, but I thought it's kind of interesting. You have this contrast blood level or contrast just pooling in the false lumen from the stagnant flow and just the weight of the contrast there. And unfortunately, a lot of motion, but you can still see there's high attenuation stuff surrounding the right coronary artery. And this was confirmed to be hemopericardium at surgery. So this was an example of acute recognized displacement of the aortic arch calcification in an acute dissection.
Yeah. Great example of that.
Now this is one I'm still waiting for it to go to surgery. David, I'm curious on your comments based on your arch experience, but this is a 3-month-old who had difficulty feeding and has, I don't remember if they had other known congenital problems or not, but here we see that they have a vascular ring, and this is a right aortic arch. We have an aberrant vessel here and a little bit of a common diverticulum. Certainly for somebody of this age, that looks a little dilated. And so I was reviewing this at our pre-op surgical conference and just trying to figure out what the aberrant vessel is here. And there's probably a left ligamentum because there's a little bit of a little divot here inferiorly towards the left pulmonary artery. But what's interesting is when you look at this, at first it looks like it's a left innominate or brachiocephalic artery that's the aberrant vessel because you have a left subclavian and you have a left carotid artery. But I noticed that this carotid looked a little diminutive relative to the right carotid. And then unfortunately, because of our contrast bolus, we've got streak here. But there's this other vessel coming from anterior that happens to be also headed up in the direction of the carotid. So I think, and this hasn't been confirmed yet because I haven't gone to surgery and they haven't done neck imaging, but it looks to me like there's separate arch origins of the internal and the external carotid arteries on the left, one of which is coming off from the posterior aspect, one of which is coming off the anterior aspect. So it's it's a vascular ring, whether you call it a double arch with an atretic segment in between here, or whether it's a right arch aberrant vessel. I thought this was a really cool anatomic variant that I hadn't seen before.
And there's no vertebral artery component to these vessels that you're seeing.
No, I think the vertebral artery's here, and it's coming off the subclavian, as you would expect.
Right.
Yeah, and
I think it's a double arch, just given the symmetry. If you scroll up toward the top, you've got this very nice symmetry of vessels.
Yeah.
There in the sternum, and and the fact that there's this anterior moiety that's crossing the mediastinum to give rise to this thing, I think is
Right here?
yeah, to give
A
rise to
little
that.
bit lower.
Yeah,
It's
it's very
horizontally oriented.
Sorry, say that, Howard?
Sorry, there's a horizontally oriented vessel right there. Yeah, the anterior arch, the left arch.
I don't know. Some of this is streak here. I don't know what.
Oh.
Yeah, that's what I was saying. It's unfortunate that we have all the contrast, obscuring things. That's why I was waiting for them to go to surgery to see if there's an atretic segment from a double arch or if this is just a vascular ring from a left ligamentum. Yeah, I also can't explain why there's this what looks like a big bronchial artery right there. But yeah, no, and I was wondering if it could be a cervical arch just because, and we've seen examples of separate origins, absence of the common carotid and internal and external origins from a cervical arch, but it's not high enough to be that.
Can you make us a coronal?
Yeah.
So, yeah, so look at that. So right there, you've got this V-shaped origin. So the vessel that's heading to the left is coming off the side of this higher entity on the right. So this is a double arch.
Okay.
So it's that that V-shaped thing, that V-shaped origin that's really really very potent here. So the left vessel is coming off the side of the right vessel. So it's coming off the side.
Yeah.
Okay. So that's a double arch. So if that right carotid were coming off the top of the right aortic arch, it would be a right arch.
You're saying if the left brachiocephalic were coming off the top of this arch, then it'd be an aberrant?
Yes.
Yeah.
That's
okay.
Yeah.
Cool.
It's a double arch.
Yeah. So so the atretic segment is between the left internal and external carotid arteries then.
Yeah. So that's another variation of a variation. Yeah. Cool.
Right. So yeah. Yeah, I thought this. I'm still waiting for the surgical confirmation, but this no surprise. This patient has narrowing of their airway and narrowing, and they were having trouble with feeding as well.
So I think the configuration on the coronal view is very helpful in determining double aortic arch.
But I do think there's also a left ligamentum, probably right here, a tiny little divot that's contributing to the vascular ring as well. So and they did subsequent genetic analysis, and this patient did have a 22q deletion, so something along the DeGeorge spectrum. So I thought you'd like that one.
Love it.
Well, here's another one you're going to like, since the two of you have taught me a lot of what I know with this entity. This is a 49-year-old. Well, at the time he was 49, and this was a radiograph taken right after a go-karting accident. Nothing at the time in terms of trauma, but then he develops worsening shortness of breath and dyspnea over years. 2018, now we can see a new finding, which is this elevation of the right hemidiaphragm. And on the lateral view, we see that it's not just anterior, that the posterior cruce is elevated as well. So that raises the suspicion of this being some sort of diaphragmatic paralysis, certainly, or just weakening rather than just an eventration. Now, this patient, and I'll come back to this finding, and this wasn't detected at the time. This was just called a little bit of elevation and atelectasis at the right lung base. And I don't know exactly, they were looking for just whatever cause of shortness of breath. He ended up undergoing $1 million cardiac workup after this too, which was all negative because they couldn't figure out why he was so short of breath. And I know I had emailed Howard and David a couple months ago in regards to a different case. I think this is a nice example of showing thinning of the diaphragmatic cruce on the right. And I'm a big fan, and I'll show the fluoro images here in a moment, but I'm a big fan of this paper that I found in JTI a couple years ago, some guy named Godwin and Pipavath and others, where you did an analysis of CT size of diaphragmatic crura and found some pretty interesting data, which I think is pretty, is pretty useful, looking at the thickness of the crus at the level of the celiac on the axials and at the level of the L1 vertebral bodies. So very sensitive and fairly specific too. So David, I don't know if you want to comment on this at all, but I like the illustrations you have in here. And, I found measuring this one, I found certainly less than 2.5 millimeters on the right at the celiac, almost double that on the left. And same thing on when I did the coronals.
Yeah, so the thing is that the other thing that's helpful just as an eyeball is the right crus is always thicker than the left, and that's not true in your case here. So although this is not as thin as they can be, this is definitely too thin because it's thinner than the left crus.
Yeah.
So that's real. And and there's some fibers that have survived probably because near the aorta there you still have a nice chunk of diaphragm muscle. So this is probably a weak hemidiaphragm, but not completely paralyzed because there's still some muscle there. It's not thinned out all the way.
And this came to my attention just because they recently did a PECSI. So this is the post-op, just immediate post-op. Now he's got atelectasis on the left, but you can see he's still got the chest tube, and they did a right diaphragmatic PECSI. Let's see if I can find the actual. This looks like it's just a free breathing, really not a lot of motion, a little bit of motion on the right. And then I'm trying, this looks like it's the sniff. So would you agree? It looks like this a little bit more of a violent sniff on that side. And
yeah. So it's definitely weak, but what really counts is not the sniff, but the quiet, deep inspiration, the slow, deep inspiration, to see if there's any orthograde motion that will distinguish weakness from paralysis. If there's orthograde motion on a slow, deep inspiration, then it's probably not paralyzed. Now, there's very little motion there. It's less than half rib interspace. I usually consider one rib interspace excursion as the lower limit of normal.
As normal, yeah. This looks like it's about a half.
Yeah. Okay. And the thing that there can be some orthograde motion that's transmitted from the other side. Usually, in that situation, the affected side is sluggish. It only follows the other side down.
Actually,
and I think it's just being dragged rather than it's passive rather than active excursion.
I think this is this you can see.
But paradox just indicates relative weakness. It doesn't tell you it's paralysis.
Right. But I think that's why I like your CT measurements, because I think that does, does help and lends more information on studies that we routinely do even before you get to a sniff test.
There's another situation that I've seen a few times, so I'd like to alert you guys to help me determine whether I'm just hallucinating. But I have seen a couple of people who have diaphragm dysfunction, hemidiaphragm dysfunction, who had falls. Like one guy fell off a roof and another was in a mountain climbing thing and fell down into a crevice or something. He fell a lot of feet. These people got pretty badly busted up. And one of these cases, we had a chest x-ray before that and then a chest x-ray after. And there was elevation of one of the hemidiaphragms after that had not been there before. It was the left hemidiaphragm that was elevated. And the fellow had, but on CT, he had normal thickness of the crus. And it looked to me as if he had, I would call it eventration, because he had, a high part of the diaphragm, but there was still muscle function around it and stuff like that. And it didn't look like a tear of the diaphragm because there were no viscera coming through a hole. There was no collar sign or anything like that. And the diaphragm looked intact. I think it's possible. I mean, I can imagine a mechanism where if you fell and hit hard and generated a sudden jolt in abdominal pressure, you could acutely stretch your diaphragm, maybe not to the point of rupture, and then acutely thereby develop an eventration. Mm-hmm. So would you guys be alert to that possibility? And if you see any cases that sort of fit that scenario, let me know, because I think there's a real entity there of, sub rupture stretching of the diaphragm acutely. I've had a diaphragm in my hand, and it's just, it's kind of like skin. You know, you could stretch skin, and you could develop a bulge. You know, most eventrations stretch out over time, so that's a slow stretch of the diaphragm. In eventrations, it gets bigger as the person gains abdominal obesity. But I think you can do that. Maybe you can do that acutely too. So please keep your eye out for any acute eventrations.
I think, you know, and it's also just important, and I know we talk about this entity a lot, but I think it's important for everyone to appreciate just how much morbidity can be associated. This guy underwent years of workup for every possible cause, cardiac and non-cardiac, and it was overlooked for a long time.
That's interesting.
This one I'll show really quick. It's an interesting cardiac case. And this is a patient who is 75, and this CT was being done pre-transcatheter aortic valve replacement planning. And he has an interesting coronary anomaly here. We see that there's an anomalous left coronary artery arising from the right coronary cusp, and it has an interarterial course. So it's passing between the aorta and the pulmonary artery at the level of the pulmonic valve. Oftentimes these have that more slit-like ostium where it's an intramural course as well. And this is the one that's classically associated with sudden cardiac death and, you know, almost always gets surgically repaired when it's recognized, especially in younger patients. Clearly, it hasn't been that much of an issue for this guy. He's 75 years old. And so they elected to leave it alone. It's kind of interesting. They did the transcatheter aortic valve replacement. And after they did his TAVR, it was uncomplicated, but then he developed chest pain a month after they did it. So then they wanted another study just to see, you know, could it be that this was compressing? And I just show it now because you can see this is a Edwards Sapien valve, and it doesn't look like there's any involvement or compromise of the ostium here. And the artery looked similar. I even made an MPR here. I just thought it was kind of interesting because we never, you know, rarely do we see this entity in older adults, and in this case, it doesn't look like it's compressing it throughout the cardiac cycle. So we almost always think of interarterial left coronary arteries as risk factors for sudden cardiac death, and certainly it is, but maybe in this guy, maybe because it's not an intramural course, that it was less of a risk and allowed him to live to be 75. But it also doesn't look like it was compromised by his TAVR. So, you know, we see interesting things on the TAVR studies occasionally.
Cool.
All right, that is all I have. And I did see that Brian had sent a link to this article talking about seeing like paravertebral pannus in the setting of rheumatoid arthritis. I guess that's what we could call that soft tissue in the thoracic spine. And so I can forward this article out too. Thank you for sending this. We'll have to look. But yeah, I'm going to show that case to a couple of my MSK colleagues and see if they have any more information on it. So I guess that wraps it up for this week.
Thank you, guys. That was
Thanks,
wonderful.
everyone.
Yeah, thanks everyone. Yeah,
Happy
Peter, if you
Thanksgiving.
got that PDF of the ECMO, that'll be great too. It looked like a nice review.
Yeah, I have it as part of the DICOM, so it should come across with it.
Yeah. So happy Thanksgiving next week, and I know I'll be back from RSNA the following Thursday, so hopefully we'll have enough people to have a conference.
Jeff said that it's plan to go ahead in that RSNA week. So yeah, that's the plan.
All right.
Yep.
Take care, everyone.
Bye.
Take care, guys.
Bye-bye.
Bye.